Okay, today we're jumping into a really serious topic, acute pancreatitis. This is an inflammatory disease that can basically pop up out of nowhere. And when it hits hard. So let's get right into it. So just think about this for a second. It honestly sounds like something straight out of a sci-fi horror movie, right? But this isn't fiction. This is the terrifying reality of what's happening inside the body during an attack of acute pancreatitis. So, what exactly is it? Well, acute pancreatitis happens when the pancreas, which is this powerhouse organ that creates all these strong digestive enzymes, sort of gets its wires crossed. Instead of those enzymes activating where they're supposed to, down in your gut, they switch on inside the pancreas itself. And that kicks off this incredibly destructive process called autodigestion. Literally, the organ starts to eat itself. So you have to wonder, what on earth could flip such a dangerous switch? While the mechanism is this autodigestion process, there are usually very specific triggers that get the whole inflammatory cascade started. Let's take a look at what they are. What's pretty remarkable is how often it comes down to just a couple things. If you look at the numbers, the huge majority of cases, we're talking 70 to 80%, boil down to two main culprits. Gallstones are by far the most common trigger, with heavy alcohol use coming in as a very close second. But, of course, it's not always gallstones or alcohol. There's a whole range of other things that can set it off. We're talking about physical trauma to the abdomen, maybe a complication from a medical procedure called an ERCP, or even just having super high triglycerides in your blood. It really goes to show just how complex this condition can be. Okay, so we know what causes it, but what does an attack actually feel like? Let's switch gears and talk about the symptoms and how doctors start to piece together the clues when they suspect pancreatitis. The absolute classic sign is this severe, relentless pain right in the upper abdomen, what doctors call the epigastric region. And patients will often describe it in a very specific way, as a pain that feels like it's boring a hole straight through to their back. And here's a really key clinical clue. People often find a little bit of relief by sitting up and leaning forward. Now, in the really, really severe cases, the inflammation can cause some serious internal bleeding deep behind the abdominal cavity. And when that happens, you can actually see these very distinct bruises show up on the skin. You might see Cullen's sign, which is bruising around the belly button, or Gray-Turner's sign, which appears on the sides. They're rare, for sure, but if you see them, it's a huge red flag for a very bad case. So a patient comes in with this story. How do doctors lock in the diagnosis? Well, they rely on what you could call a diagnostic trio. First, you've got the clinical picture, what the patient is telling them, their symptoms. Second, they run blood tests looking for those specific pancreatic enzymes. And third, they use imaging to get a direct look at what's going on with the pancreas. When it comes to the blood work, there are two key enzymes they look for, amylase and lipase. Now, amylase spikes really fast, but it's usually back to normal within about 3 days. Lipase, on the other hand, stays elevated for way longer, up to 2 weeks. Plus, it's much more specific to the pancreas. So when you put that all together, it's clear why lipase is considered the gold standard test. And this right here is a super important point that busts a common myth. You'd think, oh, the higher the enzyme numbers, the worse the attack must be, right? But it turns out that's just not true. The clinical data is really clear on this. The main takeaway is that the numbers are great for confirming the diagnosis, but they tell you absolutely nothing about how severe the case is. And that brings us to maybe the most critical step after you get that diagnosis, figuring out just how bad the damage is. Assessing the severity is everything, because it's what dictates the entire treatment plan and helps predict how the patient is going to do. To really see what's going on, doctors need to look inside, and the tool for that is a CCT scan. This isn't just your standard CT scan. They use a special contrast dye that lights up the pancreas, giving them a really detailed picture of the inflammation and, most importantly, whether any of the tissue has actually started to die. So doctors use this scoring system called the CT Severity Index, or CTSI, to grade what they see on the scan. The first part of that is the Balthazar score, and this is all about the inflammation. It's a scale from A to E, and you get points based on how things look. Is the pancreas normal? Is it just a bit swollen? Or is it surrounded by inflammation and fluid collections? Now, this second part is even more serious. This score measures something called necrosis, which is basically the death of the pancreatic tissue itself. And the more tissue that is died off, the more points you get, all the way up to 6 points if over half of the pancreas is necrotic. This is a really bad sign. So you just add the points from the Balthazar score and the points from the necrosis score together, and that gives you your final CTSI score. And the magic number here is 6. If the total score is 6 or higher, that tells the entire medical team that they are dealing with a severe case of pancreatitis, which carries a much, much higher risk. All right, so you've assessed the damage. You know what you're dealing with. The next question is, how do you calm this internal storm? Let's get into the treatment plan, because the way we approach this has changed a lot. The very first steps are all about support. And the single most important thing right out of the gate is giving aggressive IV fluids. That's to keep the patient's blood pressure up and protect their organs, especially the kidneys. Then comes oxygen, good pain control, and, this is key, antibiotics are only given if there's a confirmed infection. They are not used just in case. Now, for the longest time, the thinking was pretty straightforward. Eating makes the pancreas work, so if the pancreas is inflamed, we should stop the patient from eating. The whole idea was to rest the pancreas by making them NPO, which just means nothing by mouth. Well, it turns out that whole idea was completely wrong. And this quote from the source material says it all. It's totally direct. The idea of resting the pancreas by starving the gut, that is no longer an acceptable way to treat this. The modern approach is actually the complete opposite. We now know that feeding the gut early, usually within the first 24 hours, through a feeding tube, is absolutely crucial. It helps keep the lining of the gut healthy, which in turn helps prevent bacteria from leaking out into the bloodstream and causing a nasty secondary infection. But even with the best treatment, the danger isn't always over when the pain starts to get better. So for our last section, let's talk about the lingering threats and the kind of complications that can pop up after that initial attack. This intense inflammation can have effects all over the body. We call these systemic complications, things like lung failure or kidney failure. But you can also have major problems right at the source, which we call local complications. This could be the dead pancreatic tissue getting infected, or these things called pseudocysts, which are basically walled-off collections of fluid forming around the pancreas.